Hi everyone, my name is Jan Ford. I am a family nurse practitioner and a psychiatric nurse practitioner, and this is my partner Maddie. Jean, we went to took our psychiatric nurse practitioner together, so I will let you introduce yourself.
Hi, my name is Dr. Jean. I'm an adult general primary care nurse practitioner as well as a psychiatric nurse practitioner as well. How long have we been doing this? Because we did it around the same time.
Yes, I became a family nurse practitioner in 2018, I think.
Same thing for me, 2018.
Yes. And then we took our psych together.
At Maryville, right?
In 2020. So that didn't last long.
Yeah, and then we finished 2021. Mm-hmm. But then we were starting practicing in psych since 2019.
Yes.
We started practicing, seeing patients because, during that time they did allow NPs to do psych.
Yes,
right?
And as family and adult, we could do psych. Yes.
Yeah, we could because we do have that training.
Therapy component.
Yeah, therapy component. Mm-hmm. We only just did the medication management.
Yes. Yeah. So we just want to talk to you briefly about the transition from RN to whatever you're going into as a nurse practitioner, because it is a whole different world than being an RN. And sometimes we sit there and even think to ourselves, sometimes I just like to be an RN again. Mm-hmm. And because this is a whole different entity and a whole different set of problems.
Different set of problems, because when our last RN job was easy.
Yes.
Same day surgery.
Pre-pandemic.
Yep, pre-pandemic. So let me just rewind. Pre-pandemic. It was nice.
Yes, we enjoyed ourselves, and that's how we actually met.
Yep.
And we've been friends ever since.
Since Riverview days.
Yeah. And use each other kind of as psychotherapists every day.
Exactly. That's you need it.
Yes.
But what I wish I knew before becoming an NP. What do you think?
Boy, you're not kidding, because the role is not. There's no identity. There's no similarity to it whatsoever. I don't think it's being an RN to a nurse practitioner and going into the role as a provider, because how I started out was, I worked at a hospital, and I started out in urgent care, but 2 weeks prior, I was an RN still working in the emergency room when I got hired in my first job as a nurse practitioner at an urgent care. And they tell you to go in and negotiate your salary. And I tried, and they laughed, because I went in and asked for what I thought was, I think I asked for like $80 an hour at an urgent care.
And what did they say?
They came back with 60. And it was my first job, so I took it. And we both work in the state of New Jersey, so we have to have a collaborator. Mm-hmm. And I happened to have my collaborator at the urgent care, so she at least was there to help me. And that was my first wake up to, I made more as an RN.
A lot of people say that. People who had 30, 20 years, and just let you know, 30, 20 years of RN experience, I'm congratulating everyone who have all those years experience.
Being a nurse is difficult.
It is difficult, but it's still not the same animal as prescribing. You transitioned to the urgent care. I transitioned to nursing home, and I was rounding as the only provider for primary care, seeing older adults and trying to figure out what to do. Because some of these patients already had their own provider, but I had to round for the facility themselves. So I was on my own, and I had one person to call, and it wasn't even the collaborator.
Right. I was lucky because there was always a nurse practitioner and a physician on for a shift. Mm-hmm. But interesting, I want to just point this out. In my contract that I signed when I went on board at this urgent care, it said in bold letters that if I was ever called Dr. Ford by a patient, I was to stop what I was doing and correct them and let them know that I was not a doctor, whether I had my DNP or not, or I could be terminated.
Yeah, you're supposed. Yeah, that's a big thing. Yeah, for me, I always correct them.
And patients always call you doctor.
Yeah,
I'm always Dr. Jen.
It's too confusing for them. You correct them all the time. You correct them all the time.
But that was my first. Okay. You're doing exactly everything the physician is, but if somebody calls you doctor and you don't correct them, you can get terminated.
Yeah.
Like, okay. Yeah.
That's a big thing.
I'm like, oh, I'll remember to do that in my busy day at an urgent care working 12, 13-hour shifts with patients lined out the door. But that was the most big priority, was making sure I corrected them. So.
For me, everyone knew I was a nurse practitioner. I was allowed to use my doctorate, but every time you introduce yourself, you're supposed to say Dr. So-and-so, and I have my nurse practitioner, nurse practitioner. So you always have to introduce yourself to the patient. So, no, we didn't want to pretend to be a doctor.
No.
That's not something we do. No. We are proud to be nurse practitioners, and that's why we say that. But to go back, to that transition, did you get formally trained to see patients?
I had 3 days.
You had 3 days?
I had 3 days
in urgent care?
With the provider, yes. And then I was on my own seeing all those patients. And I come from a military Navy background where I did Navy medicine, and I was deployed and I was out in the field. So I did know how to do procedures. But there you go. Here you go. One day you're an RN, next day you're a nurse practitioner. Good luck.
So it wasn't the 3 months like they do for new RNs?
No. Oh, 3 days. I had 3 days. 3 days. Yeah. Because they were short staffed.
Yep. For me,
yeah,
I was put on the first day.
Yeah.
I had someone who just said, okay, this, and I was on my own seeing like 10, 15 patients that same day.
Yeah. My first day, I saw 45 patients.
Yeah.
Yeah. And I started during cold and flu season, pre-pandemic. So,
pre-pandemic.
Yeah.
And the documentation for nursing home is a lot. So if you don't know, you have to really cover all your bases for Medicare. Because if you miss something, they won't get paid.
Right, and your documentation too was the EMR they used at the urgent care, but I also had to know how to put in on my codes, my ICD-10 codes.
And they didn't teach us anything about billing codes, ICD-10 codes. I mean, we put in the diagnosis and stuff, but like the exact numbers, you gotta search that up.
That took me forever. So I constantly it used to drive me crazy because I constantly, on my day off, I'd have to be home trying to catch up on my charts because I had no training in putting ICD-10 codes in. I mean, now, most of the time the computers can also do it for you. I mean, we have Epic, I don't use.
There's some EHRs that automatically will tell you the billing code, but not all EHRs.
No.
Yeah, not all EHRs. And then even compared to when we were doing psych, well, we are currently doing psych as NPs, did we get formal training? Did we get to follow a provider?
Oh, no, just in our clinical.
For me, I demanded just for 2 hours just to follow the psychiatrist so I could see, how he charted. Because usually they just give you a video and say, here's the EHR, here's the website, figure it out on your own. You got like 5 or 6 patients today to see.
Yeah, no. I went from the urgent care being a family nurse practitioner to the hospital being a psychiatric nurse practitioner and rounding. Oh, yeah. And not following anybody. As a matter of fact, I had the residents. They followed me.
The residents followed you even though you were trying to figure it out?
Yeah. We were just thrown, So interesting, and that's just the first thing I always want to tell people. It's like, I always remember my first mistake was trying to figure out what antibiotic to put someone on. And of course, as soon as they say they're allergic to penicillin, and then you've got to go out on the beta-lactam rings and kind of like figure out, pick and choose your what you're going to use. And I made a mistake and didn't, and the patient had a rash and called the urgent care, and I got called at the doctor's office, and they were very nice. I mean, but you really are thrown
to the wolves.
Yes, and you have got to be able to hold your own and teach yourself because it's scary. Yes, but I learned.
You learned.
I sure did. Never made that mistake again.
Sometimes you have to make that mistake one time to understand. Let me really do my due diligence.
Yes, because you're hurrying in the urgent care because you've got a time. Everything is timed now. When you're a provider, you are now working on a clock. You're not going in, seeing your patient, doing your assessments. I mean, you are walking in, your assessment, if you're in the urgent care, the assessment's already been done. by the nurse or an MA. You go in, you read, you get 2 seconds to read the note, you go in, and then you have to go and you have to interview the patient, and you have to figure out what is wrong. And
In
as
a split second.
yeah, and as an RN, you're just like, oh boy, they didn't teach me this in school,
Usually you're just taught to just give a call and see what they're gonna say, but now you're the one who's at the end of the call, right?
You are the one at the end of the call, and you're the people that are getting called. With Maddie being in the nursing home, I'm sure there was probably nurses calling her when she wasn't there. Yeah, yeah. I mean, I didn't have that in the urgent care, but oh yeah, you're getting phone calls
After
hours, pharmacies,
clarification on orders. They were asking you to resend orders, you know you specifically sent it, or they couldn't read your handwriting. Cause for me, nursing home, you have to really.
Oh yeah,
you have to still write in the chart, and then they send
it. In the nursing home, yes. At least in the urgent care, everything was EMR.
EMR, yeah.
But luckily, we both trained under the same general physician, and
we were on our own.
Busy office with a physician up in Homedale, and he had a busy office, and he just threw us to the wolves.
Yeah, but didn't we learn a lot?
We did.
Because even though we were placed on our own, we didn't struggle.
No. They a lot of his patients actually thought that I was another provider there, and they'd be like, "We want to see Jan." And you're like, "Oh no, you don't." But and he liked it when we were there, because we would go and see the drug reps, and
he liked the drug reps. He would always have us go eat.
Nice. So he had a busy practice. As a matter of fact, I actually ended up having some of his patients for psych when I went into private practice at Red Bank. Mm-hmm. Yeah, so that's your first lesson learned. And every time you go into work, all your charts you get kicked back by billing are sitting there, and you've got to fix them on your shift between seeing patients, because your codes are wrong, because you don't know what the heck you're doing. Like, what's the code for diabetes? Now I know, I have it all in my head, but I still have to look up ICD-10 codes.
Oh, yeah.
And in psych, the ICD-10 codes are a lot shorter because we don't have as many.
Yes. And there is a part of the EHR that you could just put in the DSM stuff, and then you can just automatically convert it to the ICD-10 codes.
So when you go into a specialty, if you decide to do like trend like Maddie and I did, we both started basically in general medicine, and
then you zoned in.
We zoned into what we called a postmaster's. Mm-hmm. And we both decided to do psych, and like you said, I went into the hospital to round basically they used me as a hospitalist in psych, and I had the residents, and that's how I learned. Psych, I came from an ER background, so I had some psych behind me, but we weren't always in crisis, but not like, wow, now you're the crisis provider.
So yeah, I had a psych degree, did med surge, same day surgery, pretty much float nurse. Mm-hmm. So I had a lot of psych cases, but still it's not the same as psych inpatient. Mm-hmm. I do recommend people who go into psych as an NP to have some sort of psych experience first, to know if you really, really want to do it, because it's all about talking with people. Exactly. And if you're not a talker.
And listening. Because even though you're not a therapist, technically you are allowed to bill for supportive therapy, but your patients that you see every 4 weeks use you as their psychotherapist. And so I know everything about my patients' lives. Some things I don't want to know, but I do. And they do what I tell them. And it's just, and I'm always like, I just let them talk, because I'm not the therapist, but they've got my attention, and we're going to try to work on coping skills and goals and
coping techniques. Yes. We do discuss coping techniques a lot in my sessions. You started in the hospital, I started in community mental health, and that was brutal, like having up to 40 patients a day.
Yeah.
And you only had the 15-minute follow-ups and 30-minute initials. And you were told to get your notes done the same day, or they will write you up.
Well, I had to have my notes done before I left the hospital. Yeah. And then we went through the transitions in the hospital from whatever EMR they were using, and we all had to go through Epic. training, as you're still trying to learn your role as a nurse practitioner. Now I have to learn Epic, thank God. And even though we've all worked in facilities that have Epic, Epic is different for every facility because it's whatever package that they buy. So it's not really the same. And you're just like, oh my gosh, and then I have 12 residents following me. I didn't mind the residents. I actually liked them because they actually wanted to learn. But caveat, I did notice the difference between psychiatrists and nurse practitioners. And this is the one thing I noticed being a kind of psych hospitalist is most of my residents would stop here. When you were seeing a patient, they all like to stand over a patient. And they stopped here. They didn't look at the difference between nursing and psychiatry and medical.
No, they're focused on the area.
Exactly. As nurse practitioners,
we see the whole.
We look at homeostasis. Everything needs to be running smoothly, and that's the nursing module, that we are used, and it is the correct way to do it. Because if this isn't working here, this isn't going to work there.
Yeah, if you have high blood sugars, it can present as manic.
Absolutely. And what medications don't you get with high blood sugars? Antipsychotics, and stuff like that. And we have to always do that. But this would be the residents when they were they would do this. They would immediately walk into the patient's room and start looking at their meds and everything on the phone.
And not really talking to the patient.
Not talking to the patient and standing over the patient. And, I'd be like, okay, we got to learn how to do this. We got to sit down.
We gotta see them, look at them in the face.
Hear what they're saying. We don't need to go right on to lexicon.
Because then you're gonna miss the most important thing.
Because the hospital that I worked at had lexicon. And everyone had it on their phone. And they would start Googling every medication and coming up, and it would be like, that is the difference between us. And I think that's why nurse practitioners are so special and so popular now, because I hear from so many patients
that we listen.
We listen and we care. Florence would be proud of us. Just to say.
Florence, I can.
Yes. Because that's what nurses do. So there's a cross of a similarity. As you're an RN, what is your job? You listen to the patients. You're doing your nursing assessment. That still never goes away in your head. It's just that you're flipping it into provider assessment, but you're also listening to that patient.
And that's where time management comes in. We can always talk with the patient, but if we're not getting those documents done now, we have to carry over for the weekend. So, but before I forget, did the schools ever tell us how much it costs to be in it?
No. Another thing, lesson learned. It's expensive.
You have to renew your RN and your NP. And if you've gone on the off year, you have to pay it the next year again.
Yes, ma'am.
To be back on a regular schedule with the Board of Nursing. And it doesn't matter which Board of Nursing you use, you still have to have your RN to be renewed. And you renew your NP. Then there's the CEUs that you have to do every 5 years, and with the renewals of the RNs and NPs, right?
Yes, ma'am.
Also,
your DEA license, that is not
$888
in every state.
In every state, because remember, when we started doing it, was $777, and they just bumped it up
after COVID.
After COVID.
That's always after COVID. And then on top of it, you have your malpractices and whatever specialties that you have. I have a malpractice insurance for family nurse practitioner.
One for adult.
And I have one for psychiatry.
How much was yours? Premium.
It's not cheap.
This year. How much was yours? Estimate.
Comes out, it's a few $1,000s.
For me, it was almost $4,000. I need to get a different rate, but $4,000.
That's your family, and then you've got that, and now I've noticed with the malpractice, when I first started as an NP, I do the highest, so I do 3/6 or 2/6. I can't remember what it is like that, because you want to have it. But now, with all the popularity in weight loss meds,
they're making more expensive.
And Botox and injections and IV therapy and hormones. It
costs more.
Each little thing is a check mark
and
now.
They're gonna add.
And they add onto your malpractice. When I started, that wasn't there. It was just your general.
Yeah, I saw that. I didn't even ask for it, and they just automatically put it in.
Yes. So as I am continuing down my path, I'm opening a new practice next year, which is I went and got my board certification. I had to pay for it. in hormones, men and women, thyroid. So I'm board certified in that. I got credentialed with Eli Lilly to prescribe tirzepatide and their new one that's coming out, rituximab, and peptides. And I'm also going to be hopefully getting certified in stem cells. Well, I have to have a rider for each one of those on my malpractice insurance now. So
because
it's going to triple. Yeah. So,
and then we have the CDS in New Jersey.
Yes, we have our own DEA license, which is it's like $40. It's cheap, but it's every year. Oh, and then we also had to pay a collaborator.
And a collaborator.
Because we work in New Jersey.
You can go, some people can pay from like $300 to upwards of even almost $2,000 a month.
You have to have a collaborator in every specialty that you
in every specialty. Now, if you have a collaborator that does both, then that's
try to find a psych in a general, or
it's going to be hard.
You can't, because psychiatrists are not general medicine, you know. So, and vice versa. But these are just a little caveats, and then you think you're going to be making money. Well, I work in a blue collar. Actually, we both work in a blue collar because we work in the same county. Yes, so I was going to say township, but county in New Jersey. So we work under insurances now. Here's another caveat. Medicare across the United States pays nurse practitioners only at 85%, even though we are doing 85%, even though we do the exact same jobs as psychiatrists who gets paid 100%. Doesn't matter what you're doing as a job. Doesn't matter if you're psych, family, any of it, women's health, emergency medicine, whatever it is, we get paid by Medicare at 85%.
Wow.
Yeah. So you are at the mercy of these insurance companies. And if you are so lucky to work in a wealthy county, such as up North Jersey, and you can have cash paying patients, that's great. But down here in the blue collar, providers are few and far between. And we work under the mercy of these insurance companies. And you think what we bill the insurance company for is not what we're getting paid for.
You get a fraction.
Yeah. So we never know what we're going to get paid. Now as an RN, you know how much you were going to be paid and how many overtime shifts that you needed.
I need 2 shifts to pay for this.
Exactly.
I need 3 shifts to pay the mortgage.
Yes.
You knew.
Now you're on a hope and a prayer. And they pay you when they decide to pay you. I think that by law they have 90 days to pay you. And so, but you have staff to pay still.
You have an EHR. Yeah.
You have rent if you don't own your building. Like I said, you have an EHR. You've got to pay your billers.
Phone, internet.
Yeah, absolutely. Internet, everything. So,
rent.
I tell you, the overhead is high. And, so if you are thinking realistically about becoming a nurse practitioner, and sometimes I've really started discouraging people on it because the field is very oversaturated now.
A lot.
Because these online schools are just pumping out nurse practitioners. And we got in at a time where
it was almost about to blow.
And our practices both blew up. Coming in now, you're going to be hard pressed to start a practice.
There's a lot of NPs that still can't get even a job since last year, August, even since last year.
Exactly.
May.
So, unfortunately for situations like that, and if you're single and you're able to travel around, you need to shut up shop in an autonomous state in a rural area like Alaska. Alaska pays high for NPs because they have no medical providers. They're autonomous. You are in a practice where a person could be walking through the door with their leg coming off, and you've got to fix them. So, that's your choices. Or you do locums, and, if you've been doing working as a provider for enough years, you can kind of negotiate your prices and stuff for locums work. But it's realistically not what you think it is for.
And then the certifications, you still have to pay for them every 5 years and do the CEs. So either you travel, get your CEs, or you go online, you do your CEs, making sure you have that number.
We're up for psych next year.
Yeah, okay, we are. I just renewed my adult GERA, I think, a year ago?
Yeah, me too. I did family. But I had to pay. Now I have to go in, and now I have to pay for all these psychiatric, so, or you go to a conference for
that
days.
Cover both.
You go to a conference for 3 to 4 days, spend a couple $1,000s out of pocket that you claim on your taxes, get all your CEUs done that way. It's really an interesting field. I mean, I really like what I do, but
Oh yeah. Can't say we didn't.
no, but I really am. Listen, there's a lot of other roles out there for nurses now. You can go into medical sales, CRNA. If you're a single
RNA.
if you're a single man, single woman, and you don't have a family, and you've got ability to not work for 3 years because you can't work,
You can't work, and if they're
CRNA
gonna say work, you get
kicked out of the program. The end result of that is very lucrative and very good hours.
Starting is $200.
No, yeah, easy,
The best.
easy. We've been doing this now for I don't know how many years, and I think I'm up over between 200 and 300,000 now. Do I have anything to show for it? No, because I have such high overhead, and I'm still paying off student loans.
Those student loans, and it
Because
keeps compound interest.
these schools are charging ridiculous amounts of money for a nurse to teach herself how to be an NP.
And then getting a preceptor.
Good luck. Yeah, it's ridiculous.
You get a free one, they may, last minute back out. You get paid one, you may pay thousands of dollars, like going through NP Hub.
I had to pay for my pediatric rotation in my family because I couldn't find a pediatrician that would precept me, and I had to go to I had to go to a company and pay, and it was a lot of money. I'm telling you, I think it was probably $2,500 just to spend 8 weeks with a pediatrician.
Yeah.
It's funny, and we are in such demand, and providers are leaving by the droves.
Yeah, burnout.
And we all have to kind of band together as nurses and nurse practitioners to advocate for this profession, because we are the wave of the future. And as I tell you this, and I'm not kidding you, family nurse practitioner is going to blow up in the next few years, because no one is going into primary care as physicians. It doesn't make money.
Everyone's going for specialties like psych and the others, and they forgot about FNP and adult gero.
Yes, and there's no primary care physicians anymore, and we're losing so many.
They're retiring.
They're retiring. They're burnt out. They're tired of arguing with insurance companies. They're tired. I don't blame them. It's a brutal job, but NPs are going to be the wave of the future. So we have to advocate, and you really have to go into a progressive state. And the state we work in is definitely not progressive. With the collaborators, they've tried so many times to go independent practice, and these doctors just, they just shoot it all down. And another thing too, like the liability with this stuff. You're the one who's liable. You are the liable.
Not your collaborator.
You are in it. Yes. And you're the one making the same life decisions for these patients, and if you make a mistake,
it's on you.
It's on you, and you can lose everything. So you have to basically also have an attorney on retainer for your practice. So it's a lot of overhead, and I wish that schools would tell you this. And instead, they take your money, and they take a lot of money from you. And they leave all this out. So we just wanted to kind of give you just a brief overview.
And
the realism of becoming a medical provider. Yeah. So it is a great experience. I'm so glad I did it. We got in right at the right time. For once in our lives.
COVID.
Oh my gosh, I'm telling you. And then working through the pandemic,
that's another podcast to talk about the pandemic during our time. But thank you for tuning in to our podcast. Please subscribe, follow us.
Yes.
Tune in.
Reach out to us too, please. We can give you emails, and if we can ever,
if you have questions, we can answer in our podcast, next podcast, and
suggest topics, because trust me, we're too semi-burnt out nurse practitioners just trying to who take students. And we're trying to be real with you guys. And when I hear a nurse say, "I think I'll be an NP," and I'm like, Oh.
Let me show you the reality so you know the animal that.
How about medical sales, or
Medical
become
sales,
or
nice.
become a percussionist, a cardiac percussionist in nursing? That is
Ooh, what
three.
about?
So that is ECMO. This is a new field that's coming up, and it is a specialty as a nurse. And you are going to bring in $350,000 $400,000 a year as a cardiac percussionist teaching ECMO. ECMO came out during the pandemic. How do we think we keep these people alive? ECMO. ECMO is, I think, for a day of ECMO at the hospital that I worked at, I think to have ECMO on you for one day was over $500,000 a day in the ICU. Plus the ICU bills $20,000 a day. So they have these percussionist nurses that are specialties in this. So this is an up and coming field that, I would like to give you more, literature on. CRNA, medical education, nursing education is becoming huge. Informatics, look, we're heading into
Informatics.
We are heading into the AI.
Oh, the AI. We
So-
gotta use that.
So we've got, this is your informatics field that's going to be coming up huge in nursing. So there's so many things that you can do, because to be a nurse practitioner, I wouldn't come into this field now, but you really have to love what you do, because boy, it's
a lot of patience.
It's a lot, yeah, and it's difficult, and if you're not established, and thank God the two of us are, it's regular out there, and you're just left to hang, basically, if you don't have people mentoring you and guiding you. And we didn't. We had each other.
I suggest a mentor. Yeah.
We had each other, and
Yeah.
we still have each other, and we still every day like this. Like, what are we doing with our lives? Can you believe this? But and also, it is now your due diligence. Just one point here, that if you don't check the PMP. Okay, the PMP is a computer program that is, we have it on the East Coast. It includes Puerto Rico, the Virgin Islands, the VA now, and I think the Guam.
Wow.
Yeah, I think Guam's on there now, or one of them, but the British Virgin Islands are. That is your due diligence to check on controlled substances.
Because a lot of people do doctor shop.
They do doctor shop, and they'll pay cash, and my goodness.
And it shows that they do cash or commercial or Medicaid.
And we all, and I'm guilty of sin about getting, your PMP is not a user-friendly program. Luckily my EMR goes into it, but it only shows New Jersey. It does not show.
But if you have someone in that state, then you can only switch it to that state.
Right. So you always feel stupid when the pharmacy calls you and says, "Hey Jan, because most of the pharmacists know me in the area, I just wanted to give you a heads up on one of your patients. Do you know that they're getting Vicodin from this provider? They're getting, sleep medication from this provider. They're getting, because we work in psych, benzodiazepines for you, or ADHD meds for you. And
then something for the sleep-wake disorders.
Yeah, and you've been seeing this patient for years, so you start to trust them. And then you feel like you've been completely betrayed, but bottom line, it's on you. I didn't check. And I'm the first one to say to the pharmacist, you know what? I didn't check.
Well, thanks for joining us today.
Yes.
As we unpack the transition from RN to NP, if this episode helped you, please share with a fellow nurse, or tag us on our Instagram, on our what do you call it? What do you call that thing again? Not Snapchat, the other one. TikTok.
I don't have TikTok, but
we'll have to get it. We have our TikTok. So so please tag us, share us on Facebook.
This is just real.
We're here. All right.
We're here to help you.
We're here to help you, and you have a good day.
Yes. Take care, everyone.
Bye.
Bye.